Good afternoon. My name is Greg Tinney-Crook, and I would like to talk to you about sperm and embryo selection. Many couples undergo fertility treatment, but all of them have one common goal, and that is to have a baby to start their families. Many fertility treatments out there and available, and many fertility clinics. But all these treatments and all the clinics want to have one common aim, and that is to give you your live birth. Fertility treatment is complex, with many aspects to consider. These include egg collection, the fertilization procedure, and embryo transfer. Identifying the best eggs, sperm, and embryos is essential to ensure that you get what you came for. Under natural circumstances, the body assists in the selection. Since the cervix blocks dead sperm, and only the foster swimmers move up to the fallopian tubes. And also the body normally rejects abnormal embryos. So in fertility treatment, the trained embryologist needs to step in to assist. So let's talk about sperm selection for a bit. What is sperm quality? Well, from a reproductive viewpoint, it is the capacity of a single sperm to fertilize an egg, create a developing embryo with the ability to implant, and evolve until a live birth is achieved. So why is there a need to find the best sperm? This is mainly because fertility treatment is not 100% effective. Regardless of the source of sperm, not every patient succeeds, and several attempts may be needed. In fertility procedures, it's the embryologist who chooses the sperm and is participating in that selection. Selection of one sperm may result in a good embryo resulting in a live birth, and selecting another may lead to failure. So for the embryologist, there's no pressure. Let's talk about the methods that are chosen for sperm selection. Basic is really just semen preparation, taking a semen sample and then extracting the best sperm. This is basically done as is a self-selection procedure. The best sperm select themselves. So for preparations of semen samples for artificial insemination or IVF-ICSI, this is done usually through a swim-up method or a density gradient method. Sperm select themselves on the basis of their motility or their percentage of moving sperm, the way that they're swimming. This procedure is independent of the embryologist. Then we can talk about morphology. So morphology is the shape of the sperm. Sperm morphology can be assessed as a selection method. This is, however, a subjective assessment because the embryologist is subjectively assessing what the sperm look like, dependent on the skills of the embryologist. So a sperm has a head, a neck, and a tail. All of these should be in proportion and should be nicely shaped and in the correct anatomy. Of sperm available in an ejaculated sample. So the embryologist needs to select those sperm based on the morphology. As you can see, there are many things that can be wrong with a sperm, both in the head, the neck, or the tail. And so selection of the normal sperm is tricky, but is essential. So using a very high-powered microscope and some injection or what we call pipettes, glass pipettes, they are placed into the dish with the sperm. The sperm is then assessed, and with the best morphology are then selected for the ICSI procedure. Then we can have a look at some advanced selection methods. The first of these that we will discuss is PICSI. The acronym ICSI stands for intracytoplasmic sperm injection. And PICSI is physiological ICSI, basically based on the ability of the mature sperm to bind to droplets of hyaluron on a PICSI dish. So PICSI makes use of a specific dish that selects for physiologically mature sperm. As you can see, there's an example of a sperm at the bottom left there. Sorry, example of a dish at the bottom left, where the sperm are then placed onto, and the mature sperm then bind to the dish. This is an example of one of the droplets under high magnification, and the sperm that are mature have bound to that dish. The embryologist will now use the microscope and select those sperm off that droplet based now on morphology. So they are basically combining the maturity of the sperm with the morphology to select the best sperm. Then there is IMSI, and this is intracytoplasmic morphologically selected sperm injection. And this is a method of unstained, live, high magnification sperm examination. So with a plain ICSI, done under high magnification, but not as high as IMSI, one might miss the morphology or the defects in the sperm that are seen when you do IMSI. And in IMSI, as you can see in this picture, there are, you can see very fine detail in the sperm, including vacuoles in the head of the sperm, and that is what is DNA integrity is crucial in order to release the paternal genetics properly to the egg, resulting in a healthy child. DNA may not be able to perform its task properly. Various tests that are done to look at the integrity of the sperm DNA. There's a lot of information out there which is often very confusing, and a number of scientific articles and reviews are available, but they do have conflicting results. So the European and American fertility societies have said that the existing data does not support a consistent, strong relationship between abnormal DNA integrity and reproductive outcomes. There is insufficient evidence to recommend the routine use of sperm DNA integrity tests in the evaluation and treatment of the infertile couple. However, I do know that many clinics do include DNA fragmentation as part of their semen analysis. We can have a look at using testicular sperm. It is reported to be of benefit when using testicular sperm instead of ejaculated sperm in certain cases. For patients with very low sperm count or high DNA fragmentation, it might be beneficial to go to the source of the sperm in the testes and gather those sperm for the procedure. There are some studies that show benefits, but the quality of the information is not that good, and there is need for more trials to determine if one should be going down this route. There are other selection methods that can briefly be looked at, but I won't spend much time on this. Firstly, there is magnetic activated cell sorting. This is done to select non-dying sperm, and there have been articles that shown benefit for artificial insemination and IVF, but it's not cost effective and it's not really used in many labs. electrophoresis. And this is taking the highest quality sperm and separating it based on their negative charge. It's not a superior method and is difficult to implement. And then there is birefringence. And this is based on the ability of light to pass through the sperm head, but it has been shown that it's not beneficial. So to close off this section on sperm selection is a vital part of the fertility procedure. However, currently doing it is yielding relatively poor results. So many of the advanced sperm selection methods lack good scientific evidence to support their generalized use. There is no one-fits-all sperm selection method able to significantly improve success rates. Good sperm is possible, but finding the best sperm is difficult. Now I'd like to move on to talking about embryo selection. A patient having fertility treatment might have multiple embryos, and it is the embryologist's job to select the best embryo to transfer or to freeze. And in order to make sure that we give the patient the best possible opportunity. Both non-invasive and invasive methods to do embryo selection. These include morphology and media testing, and also pre-implantation genetic testing. Embryo selection based on morphology alone has not resulted in high success rates. This has resulted in a strong drive for finding alternative selection methods. We'll briefly touch on the non-invasive treatments. We can have a look at the timing of division and the quality or fragmentation within an embryo. So if we look at timing of division, basically an embryo needs to be at a certain cell stage on a certain day of development. So it will start off as a 1 cell, become a 2 cell, then a 4 cell on day 2, an 8 cell on day 3, a compacted embryo on day 4, and then a blastocyst on day 5. And if the embryo has not reached that stage yet for that particular day, it is deemed to be not as good quality as others that might have reached that stage. Then we can look at the fragmentation in an embryo. Basically, once those cells divide, they should divide equally, and there should be no bits and pieces that are left behind during the division. But this is not always the case. And so there is, as I say, bits and pieces next to all of these cells. And this is called fragmentation. And the higher the percentage of fragmentation, the lower the chance that that embryo will result in a live birth, a live healthy birth. So we can use both timing of division and quality or fragmentation to determine which is the best embryo. We can also have a look at blastocyst grading. So a blastocyst is the day 5, 6, and 7 embryo stage. And the blastocyst has various parts to it that can be graded, and we can give each embryo a grading. So this is an example of a grading system. The first column shows the expansion of the embryo, and the bigger the embryo gets, the better quality it is supposedly going to be. Then there is the second column, and that's grading the inner cell mass. And there is a small blob of cells in the blastocyst that is called the inner cell mass, and that actually becomes the fetus itself. And the tighter, more compact that inner cell mass is, the better the quality embryo. And then lastly, we can grade what we call the trophectoderm. And this is the lining of the blastocyst. And this eventually becomes the placenta. And the more regular and nicely spaced the trophectoderm cells are, the higher the quality. So one can then start to grade embryos, and this is just an example. As you can see, the embryo on the left is a 3AA, so it is the biggest it can be, and it's got top quality inner cell mass and trophectoderm, and that is the embryo that we would then choose to transfer or freeze. Time lapse or morphokinetics. Normally, on the days of assessment of the embryos, they are taken out of the incubator and assessed only once under a microscope. This gives a static picture of the developing embryo. Time-lapse uses an incubator with a built-in camera for automated imaging of the embryos in a closed incubation environment from fertilization to embryo transfer. This system allows the embryologist to distinguish and choose normal developing embryos with good implantation potential. There are some other non-invasive methods, including oxygen consumption of the embryos, at biochemical markers measured in the droplets of culture medium that the individual embryos are cultured in. But these are not readily done in laboratories. They are more research orientated. I'll briefly look at the invasive method of embryo grading, and this is pre-implantation genetic testing. PGT allows the embryologist to distinguish between chromosomally normal and abnormal embryos, or what is called euploid versus aneuploid, normal versus abnormal. And this is an invasive method whereby cells are actually removed from the embryo and then sent to the genetics lab to be tested. And then the embryo is kept in the fertility clinic while the cells are tested, and then the result is released whether the embryo is normal or not. The advantage of PGT is that one has the knowledge that a chromosomally normal embryo is being transferred into the patient. However, there is much data indicating that PGT should not be offered to all patients and only to those patients that fall into certain groups. So that is the end of my talk. We've had a look at sperm selection and embryo selection, but all in all, we're looking to have that one final goal of having a healthy baby to start your family.